Hello, Christy. How are you?
Good.
Good. My name is Andre. I am a nurse practitioner student at Youngstown State University. And today I will be doing an assessment on you on your heart, chest, and lungs. Is
Okay.
that okay?
Yes.
All right. It should take about 15 minutes, okay?
Sounds good.
So right now, starting off, I am looking at her. Her breathing, her chest. I'm seeing that she is not tripoding, no use of accessory muscles. She's breathing even and regular, and that is all normal findings. Also looking here, we're going to be looking at the AP diameter of the chest. The AP lateral diameter should be twice as wide as the posterior. Normally you can measure this, but generally you can visualize this. The lateral surface is 2 times than the posterior surface, which is normal. Also, I do not hear any audible wheezing. There's no distress. Like I noted, no tripoding. She is sitting upright. She has good posture. And respirations are regular, even, and unlabored. So what I'm going to do now is I'm just going to look at your fingers here. I'm looking at the nail beds. They are of normal color, no cyanosis. Pallor is good. I do not see any cyanosis around her lips or on her face. Lips are moist and red. And no pursed-lipped breathing or nasal flaring indicative of having trouble breathing, which is all normal findings. Right now, I'm just going to check the trachea. It is midline without any evidence of tugging, so that is good. And clavicles are present superiorly. I do see those. And along with this, we're just going to check for clubbing with your hands. If you could just hold them out like this for me. All right. And just do one finger at a time. And just checking for clubbing of the nail bed, which could indicate chronic hypoxia. They do look normal at this time, which is good. What I'm going to have you do is I'm also feeling the chest for any crepitus, any air that is trapped underneath the chest here. I do not feel anything, which is good. And the manubrial sternal junction, which is right here, or the angle of Lewis, I am able to palpate that. It is visible and can be palpated at the angulation of the sternum. What I'm going to have you do next, I'll just have you lie down on your back.
Okay.
And again, just overall inspection of shape, size, and symmetry of the chest. No protrusions, no sunken spots. It is regular in size and proportion to the rest of her body. The chest does appear to be symmetrical to the front, and the costal angle is less than 90 degrees. Her ribs do appear to be correctly anatomically, and no protrusions of ribs noted. The angle of the ribs is approximately 45 degrees and is normal in prominence as well. Here you would also be counting respirations. She's at 14, which is normal. They are easy, regular, and unlabored. Chest wall is symmetric with respirations, and no use of accessory muscles or nasal flaring with breathing. I'm going to palpate your precordium now. So I'm going to be starting at the left sternal, and I'm just going to be feeling down at the apex, going down to the apex, which is at the 5th intercostal space, mid-clavicular line, working my way up the sternum and down the right sternal border, feeling for any masses, lesions, or crepitus, which I do not feel, and using the base of your hand or your ulnar side to be able to do this. I will be checking her apical pulse now, which is the 5th intercostal space, mid-clavicular line. I will be feeling there, and it is present. And if I could have you lay on your left side, this does bring the apex of the heart closer to the chest wall, so it is easier to palpate. And it is present, and I am able to feel that there. And I will have you lay back on your back, please. Checking for any thrills or heaves. I am noticing I do not see anything with that. Heaves are sustained impulses that indicate hypertrophy of the right ventricle. And also I do not feel any thrills, and no heaves are noted. I am going to check for JVD, jugular vein distension. And I will have you look to your left, and you're just looking for jugular vein distension, which I do not see. Can you look to your right, please? All right, very good. And then what you would do is you would also bring the head of the bed up to a 30 or 45 degree angle. And I would just check again for JVD. Look to your left, please. All right, good. I do not see any. And then look to your right. And I do not see a presence of JVD on that side. What I would do next is listen to the carotids with the bell of the stethoscope, both the left side and the right side. All right, so the carotid I was able to auscultate that, and there was no thrills noted with that. Checking for heart sounds now. I will be listening to the 5 heart sounds. First one is second intercostal space at the sternal border on the right side. That is the aortic valve. And then left second intercostal space, sternal border, that is the pulmonic. Going down in between the base and the apex, that is Erb's point. Tricuspid valve. And then listening at the 5th intercostal space, midclavicular line, is the apex of the heart, which is good. And then I would also listen with my bell for murmurs, which does has a low pitch. So I would start again. Aortic, pulmonic, Erb's point, tricuspid valve, and then the mitral. Again, you would have them lie on their left side. All right, and I'll bring your hand here.
Okay.
And I'm going to listen again. Just listening for those murmurs. Left side, the aortic, pulmonic, Erb's point, tricuspid, and mitral. All right. Very good. If I could have you sit up, please. All right. So what I'm going to have you do is I'm going to have you inhale, hold your breath, lean forward for me. We're just going to listen to those murmurs again, if there are any present, again at the aortic, pulmonic, Erb's point, tricuspid, and mitral. So no evidence of murmurs noted. If a murmur was heard, this is something that you would document. You would document the timing, duration, pitch, grading the murmur from 1 to 4, the intensity, pattern, quality, location, radiation, and variation with respiratory phase. If you were to hear a thrill, you could then would reassess by checking for a thrill. So I see here the patient does have good posture. Her arms are at her side. She's able to take good deep breaths. And I'm going to listen to the front for lung sounds using the diaphragm of my stethoscope. 1, all right, good. Breath in, breath out, good. Good. And then the side. And make sure to get up by the axilla so that you are getting lung tissue. All right, good. So breath sounds are vesicular, no evidence of adventitious breath sounds, no crackles or rails noted, no evidence of wheezing, rhonchi, stridor, or friction rubs noted on auscultation. All right, and with the patient sitting up now, what I'm going to do is I'm going to listen to her heart sounds while she's sitting up with the diaphragm of my stethoscope. It's going to be the aortic at the 2nd intercostal space, right sternal border, pulmonic at the 2nd intercostal space, left sternal border. Erb's point is the middle between the base and the apex of the heart. Tricuspid is at the third intercostal space, left sternal border, and then mitral at the fifth intercostal space, midclavicular line. So listening to those, rate and rhythm are regular. S1 and S2 were both heard. S1 was louder than S2, which is normal. No evidence of S3 or S4 sounds heard. No splitting noted. S1 is the tricuspid valve and the mitral valves closing, whereas S2 is the aortic and pulmonic valves closing. Now what I'm going to have you do is just lean forward. That does help to bring the apex of the heart closer to the chest wall. And with the bell of my stethoscope, we're going to listen to those low-pitched sounds. We're going to be listening to if she would have any murmurs. And we would just listen to those stomach sock spots. I'm going to have you breathe in and hold. Aortic, pulmonic, Erb's point, tricuspid, and mitral. All right, I'll just have you sit up and you can breathe normally now. So no murmurs were heard. If murmurs were to be heard, you would note and document the timing, the duration, pitch, the grade of the murmur from 1 to 4, the intensity, pattern, quality, location, radiation, and then variation with respiratory phase. If you were to hear a murmur, you could then reassess with a thrill. So I do see the patient here is sitting with good posture, has her arms to her sides. She is able to take good deep breaths, and I'm going to listen to her lung fields. All right. With the diaphragm of my stethoscope, just breathe in and out. Good. 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 And then you're going to listen laterally. And then on the other side. And you want it up close to the axilla just to make sure you have lung tissue to listen to. All right. So breath sounds are clear. They are regular and are vesicular. No evidence of adventitious breath sounds. No crackles or rails noted. And no evidence or audible wheezing, rhonchi, stridor, or friction rubs. And what I'm going to do here is listen to her breath sounds. So I'm going to have you cross your arms and just lift. That does help bring the scapula away, so it gives me more room to listen to her lung fields. All right, so just breathe in through your mouth, out through your mouth. Of course, if you feel dizzy or short of breath, just let me know and we can take a break.
Okay.
All right. Good. All right, deep breath in. Good. And then deep breath in and out. All right. Listen to the lateral sides. All right, good. And you can place your arms down. So breath sounds are vesicular, and no evidence of adventitious breath sounds, no crackles or rails noted, no wheezing, rhonchi, stridor, or rubs noted. I'm just going to inspect the back now, checking for shape, size, and symmetry. The shape is good with proper contour. It is symmetrical. Spine is midline. No spinal deviations or protrusions noted. I'm just going to palpate at the spine and just see if there's any pain or tenderness. Are you having any pain?
No.
All right. And just go all the way down. No depressions or masses noted. No evidence of crepitus. And then, of course, no pain or tenderness throughout the back here. What I'm going to do next is thoracic expansion. You're going to have your hands at the lower part of the ribs and kind of have your thumbs like this, press forward, And then just have them take a deep breath in and out. All right, good. In and out. All right, very good. The chest wall does move symmetrically on both sides, which is what we want to, which is an expected finding. And then palpating, what I'm going to do is for checking for tactile fremitus. Every time you feel my hand move to a new location, I'm going to have you say the word 99.
Okay.
All right.
99. 99. 99. 99. 99. 99. 99. 99.
All right, and then the side.
99. 99. 99. 99.
All right, very good. So tactile fremitus is present and is intact, which is normal. And then again, I'm going to do this with the stethoscope. Every time you feel the stethoscope, just repeat 99 for me.
Okay. 99. 99. 99. 99. 99. 99. 99. 99.
And one more time.
99.
And again.
99.
Again.
99.
And one more.
99.
All right, good. And again, tactile fremitus is present and intact, which is normal. You should hear the higher you are, and as you go down, it should be clear up here. This is testing for consolidation. And as you go down, it should become muffled, and this could mean if it does, there could be consolidation. Along with this, there is the cacophony test, which you would do the same thing. You would have the patient say E, and if you hear the letter A, that could mean there is consolidation. And then there is also the whisper test, which can be performed to check for this as well. Vocal resonance is both present and indistinct. So the next thing I'm going to do here is percussion. What I'm going to do is be feeling for diaphragmatic excursion. So on the left side, I'm going to go all the way down until I hear a dull sound, which is right here. And then I am going to take a piece of tape and mark this right here. And then on the right side, doing the same thing, making sure my finger is flush with the body to get a good sound. And then as soon as I hear that it is dull, I will put a piece of tape. All right, good. And then also what I'm going to have you do, I'm just going to have you exhale and hold your breath. All right, it is dull there. All right, take it. You can let your breath out now. All right, good. All right. And then we're just going to do the same thing. I'm just going to have you exhale and hold your breath. All right, and it is dull right here where I did lose resonance, which is good. Take a breath for me, please, and breathe normally. And then what I'm going to have you do is I'm going to have you inhale, hold your breath, and you're just going to go up from the point. All right, good. All right, and this is where I hear it at, so I'm just going to mark it with a piece of tape. All right, breathe normal for me. All right, and then I'm just going to do the same thing on the right side.
Okay.
So I'm just going to have you take a deep breath and inhale in and hold. All right, right here. Now normally this would be done on the patient's bare skin, which would be easier to see. And then using a tape measurer, I would measure. And here we are. So we are at 3 centimeters for her diaphragmatic excursion, which is normal. Normal is 3 to 5, so that is good. This does end our assessment. Do you have any questions or concerns?
No, I don't.
All right, thank you, and I'll see you soon.
Okay.
All right, so this is a correction to the previous video that I did for the assessment for this class. I just want to make sure that when I'm looking over her general appearance, that I'm looking at the trachea, making sure it's midline. There is the angle of Lewis here, and then right above it is the suprasternal notch. And then using my pen light, what I want to do, I will have you lay down. And what I will be doing is just inspecting, looking at this chest, and I will be looking to see if there's any evidence of heaves or lifts, which I do not see. And a heave could be indicative of right ventricular hypertrophy. So I do not see any of those noted. And then what I'm going to do is I'm going to palpate for thrills over each heart valve. So starting at using the palm of my hand, starting at aortic, pulmonic, tricuspid, and mitral. And then if I could have you go to your left side. And then I'm just going to feel for that apical impulse on this left side. And no thrill or pulsations are noted. So I did not see any lifts or heaves, and I didn't feel any thrills or pulsations.